So my name's Claire. I'm a physiotherapist working with Calvary Healthcare Bethlehem in Australia, and today I'm going to talk about our systematic review on exercise interventions for people with ALS MND. I want to acknowledge my supervisors and a big thank you to MND Victoria who funded this review. I also wanted to acknowledge the 910 participants within the studies that were in our systematic review. Without all of these participants, this systematic review wouldn't have been possible. So first, I want to talk about why we felt a systematic review would be helpful in this space. While not all people with ALS MND feel strongly about participating in exercise, there's definitely a group of people who feel really strongly about wanting to participate in exercise as part of their disease management. So one person with MND said, "I knew there were so many benefits with exercise and I wanted to give it my best shot at keeping my body strong and healthy for as long as possible. It felt like everyone gave up on me when we talked about exercise, and it's frustrating that there's no clear answers." So this group of people really wants to know, should they exercise? What type of exercise should they do? How much exercise should they do? And what effect is the exercise going to have on their disease? So our primary research question was to understand the efficacy of exercise on disease-specific and functional outcomes in people with ALS MND. And our primary outcome measure was the ALS FRSR scale, which is a scale of physical function. But also we really wanted to pay attention to the important information in the clinical prescription of exercise. So we wanted to understand how different types of exercise, how people respond to different types of exercise. We wanted to understand how people at different stages of the disease respond to exercise. And we wanted to understand how people with different ALS MND phenotypes respond to exercise interventions. So I'm not going to go into too much details about the methodology of our review. It's registered with Prospero if you want to look up more details. We included all phenotypes of ALS MND, so ALS, primary lateral sclerosis, primary muscular atrophy and progressive bulbar palsy, and any other ALS phenotypes. We included RCTs, non-randomised controlled trials, and we included single group intervention studies because we know it's really hard to recruit participants to clinical trials in this population, and we know there's lots of really helpful clinical information out there in those single group intervention studies. We included all exercise interventions and we included all outcome measures, but as I said, our primary outcome measure was the ALS FRSR, or a patient-reported scale of physical function. We screened almost 7,000 articles, and in the end we had 31 studies included within our systematic review. So now looking a little bit into the demographics of the people included in our systematic review, all of the participants across all of the studies had the ALS phenotype of MND, and people with other phenotypes of the disease were not represented in the literature at all. We also noted that a lot of the studies had eligibility criteria around physical function. So 36% of studies had eligibility criteria around the ability to walk, 22% had criteria around the stage or duration of the disease, and 39% had criteria around FVC or lung function. Looking again a bit closely at who was actually included in these studies, the mean ALS FRSR, so functional rating scale of participants, was 38 out of 48. And you can see on that scale there on the screen that within each of the studies, the mean functional rating scale of the participants was towards the higher end of that scale. And the same thing was true in terms of lung function. So the mean forced vital capacity was 88%. And again, within each of the studies, the lung function of the participants was towards the higher end of that scale. So this was really important for us to consider when we were interpreting our results, because a lot of the participants were at earlier stages of the disease and had minimal functional impairment at baseline. So next I'm going to talk a little bit about what types of exercise were included across the literature. We analysed our data based on the type of exercise. So we had categories of aerobic exercise, resistance exercise, respiratory muscle training. We had an other respiratory intervention category, which included things like diaphragmatic breathing, respiratory swallow coordination training was included in that group. We had an other exercise category which included some studies that had robotic-assisted gait training or robotic-assisted upper limb training. And then we had a lot of studies that included more than one type of exercise within their intervention protocols. So we grouped these into a mixed exercise category. Most commonly, these studies included an aerobic component, a resistance component, and a stretching or range of motion component. When we grouped all of those studies together, we saw there was a really clear delineation between studies that had systems or protocols in place to ensure participants were exercising at a moderate intensity. So they used things like a rate of perceived exertion or heart rate monitoring to ensure participants were exercising at moderate intensity. So that group was split into moderate intensity and low intensity mixed exercise. So overall, we found that there were low levels of attrition. The overall attrition rate was 15.85% across the literature. There were really low numbers of adverse events. Only 11 adverse events were reported in total across the literature at a rate of 2.39%. And although it wasn't reported consistently, when it was reported, the adherence to the exercise protocols was high. But important to remember that this was among participants who were at earlier stages of the disease and who had minimal functional impairment at baseline. So I'm not going to talk about all of the results from our systematic review today, just a few of the key exercise categories. Resistance training I'll talk about first. We had 4 studies included within our resistance training group, and you can see there that the attrition and adverse event rates were slightly higher than the overall attrition and adverse event rates. Unfortunately, in this group, there was really varied outcome measures that were used and really varied comparison groups that were used. So that really limited how much meta-analysis we could perform in this category, and we couldn't perform any. And there wasn't any real clear conclusions or trends in how the resistance training affected the functional rating scale, muscle strength, or any of the other outcomes. One of the things that was really interesting in this category, out of all of the exercise studies that included a resistance training component in their protocol, 12 of 16 of those modified their exercise significantly. So some avoided the concentric phase of contraction, some avoided the eccentric phase, and some modified both phases of contraction, or they avoided strengthening weak muscles altogether. So across this resistance training group, there were really conservative resistance training protocols, and particularly when in regards to strengthening or exercising muscles affected by ALS MND. Next, I'll talk about respiratory muscle training. So this was our biggest category in terms of number of participants. There were 7 studies in this category. Some of the studies used inspiratory muscle training, some used expiratory muscle training, and one study combined both inspiratory and expiratory muscle training. Again, we had a real variety of outcome measures which limited the meta-analysis that we could do, but we could perform some meta-analysis within this group, which I'll show you on the next slide. In terms of the outcomes, though, there was inconsistent results for measures like peak cough flow, swallowing function, quality of life outcomes, physical function or lung function. But across the literature, none of the studies reported that their outcomes deteriorated at a faster rate in the respiratory muscle training group than they did in the comparison group. The respiratory muscle training groups either performed the same as the comparison groups or slightly better than the comparison groups. So this is the meta-analysis that we were able to perform within this category. We compared respiratory muscle training with sham intervention on the ALS functional rating scale. And as you can see there was no significant, neither of the groups were favoured significantly there. We compared respiratory muscle training with no intervention on forced vital capacity or lung function. And you can see the results maybe slightly favoured the respiratory muscle training group but did not achieve statistical significance. We then were also able to compare expiratory muscle training compared with sham intervention on maximal expiratory pressure, so a measure of expiratory muscle strength. And we can see there that clearly the results favoured the respiratory muscle training group and they achieved statistical significance. So we showed that expiratory muscle training improves expiratory muscle strength, but whether or not that translates into physical function or lung function is still unclear. Next, I'll talk about our mixed exercise category, so exercise protocols that included more than one type of exercise, most commonly resistance, aerobic exercise, and stretching or range of motion exercises. In this category, a lot of the studies reported on the functional rating scale, which was really nice. And 5 out of the 6 studies that reported on that scale reported that the mixed exercise category group improved significantly when compared to a comparison group. Unfortunately, there was differences in the comparison groups used, which was one of the factors that limited how much meta-analysis we could perform here. And again, within this category, across all of the studies, across all of the outcome measures, the mixed exercise group either performed the same as the comparison group or slightly better than the comparison group. None of the outcomes deteriorated in the mixed exercise at moderate intensity interventions. So this was the meta-analysis that we could perform within this group. We compared mixed exercise performed at moderate intensity compared with usual care on ALS functional rating scale. And you can see there that the results favour the mixed exercise category and it achieved statistical significance. And the mean difference here was 13.22 points, which has already been established to be a clinically significant level of improvement in this scale. So in summary, we found that exercise is safe, tolerable and feasible for people with ALS MND. This is evidenced by low levels of attrition, low levels of adverse events and high adherence to exercise protocols. We did find that there were lots of limitations across the literature though, so there was high risk of bias across most of the studies. As we'd expected, there were small sample sizes, and one of the biggest limitations we had in terms of this systematic review was the inconsistency in exercise protocols, the outcome measures used, and the comparisons groups that were used. Given we know it's so hard to recruit enough participants to well-powered, randomised controlled trials, it's really important that researchers consider these factors when designing their trials, because it's likely that these important clinical questions that we have about exercise are going to be answered through future systematic reviews. In terms of our research questions, it was unclear which type of exercise was most effective. We couldn't answer that question, but we could show that mixed exercise at moderate intensity might slow functional decline, and expiratory muscle training might improve maximal expiratory pressure. In terms of how people with different phenotypes respond, we couldn't answer that question either because only participants with the ALS phenotype were represented within the literature. So more research is needed amongst people with other phenotypes so they can understand how they might respond to exercise interventions. And all participants in this review had relatively early stages of the disease and limited functional impairment at baseline. So this should be a priority for future research so that people can understand how they might respond to exercise across the spectrum of the disease. And finally, I'll leave you with some clinical considerations. So while not all people with ALS MND feel strongly about wanting to participate in exercise, there's definitely a group of people who find exercise is really important to them and they feel really strongly about wanting to participate in exercise. And this group wants clear, practical, specific information about how they actually should go about exercise. Exercise should be monitored. In particular, high-intensity exercise should be monitored by a health professional because it's not being tested in the literature at all. It's important to consider exercise in the context of the person's life, and as physios, it's important for us to consider and work with the patient to establish if we need to be prioritising meaningful activities and activities of daily living over structured exercise programs. And then finally, it's important to openly discuss the uncertainty and limitations of the evidence so that people with ALS MND can make can make informed decisions about exercise within the context of their disease and within the context of what's important to them. Here's our contact email address. Feel free to get in touch if you have any questions or if you need any more information. Thank you.
Thank you, Claire. That was really interesting. Does anybody have any questions? There, question in the room.
This is an online question, and it is, what would be included in mixed exercise?
So our mixed exercise category was the studies that included more than one type of exercise within their exercise protocols. And as I said, most commonly this consisted of an aerobic component, a resistance or strengthening component, and a stretching component. But this was our group that was least consistent in terms of exercise protocols. But we had to group those in together as closely as possible. So that's why we had the intensity element within those categories.
There. Can I do one more? Yeah. How has this changed your practice?
I think the biggest thing that it's changed is it just gives me a lot more confidence going into that clinical discussion. It's not that I've been armed with new information about exercise or a new way of approaching exercise. It's more that I've got all the information I need to openly discuss where the literature is, where the evidence is, and help people make the decisions about how they want to use that information.
There's just behind you, yeah.
Hello. I like your considerations, and it brings a question whether you find in your review whether the person liked doing exercising before the diagnosis or the symptoms of ALS. So did they like before? They didn't, probably they will like after. So that is a key question, whether they would like to embrace that. And the second question, if I may add, is in those that did exercise, does the review shows an increase of falls after exercise, and that's something that we call pseudo-weakness when somebody fatigued the muscles?
The first question, so clinically, I think, and this is the same in other populations, there's a certain group of people who really identify within their exercise. So they're runners, or they play soccer, or they do different physical activity as part of their identity. Those people definitely feel really strongly about continuing exercise. There's probably also a group who use exercise as stress management, or it's kind of their pre-existing way of going about life. So those people feel really strongly about it clinically. But that's definitely a big gap in the literature. There's not much qualitative information about what people with ALS MND want to know about exercise and why they want to know it. So I think that would be a good space for future research. And then in terms of the second, could you just remind me the second part?
Sometimes when people do a lot of exercising, they have a pseudo-weakness, which is they are exhausted and they wake up the next day and they fall because they exercise too much. Did they mention risk of falls as an outcome of risk of exercising?
Just going from memory, I don't think, and this was one of the things we were interested in, none of the studies really looked at balance exercise or balance retraining. And I don't think any of the studies looked at the rate of falling. I can check that for you and be 100% certain, but I think that was a real gap in the study. We didn't have much information about falls.
I have a question online.
Well, it actually follows that beautifully, because it was, did your research find any trends about exercise reducing falls or other harm?
Yeah, I think this was really interesting. We expected there'd probably be a balance training category when we were first thinking through how we'd categorise the data, and balance was never the primary intervention. Some of the mixed interventions included a balance training component, but again, the outcomes weren't really clear enough for us to know how balance training affects falls risks or how effective it is.
Question here.
Thank you so much. It's really important to bring these topics to consideration. I always love it when someone comes with an exercise retrospective or looking at the literature. The Clausen paper actually did look at falls, and so you might go back and take a look at that. I think they did show an increased number of falls in the individuals that were randomized to the resistive training arm. It was not statistically significant, as I recall, but they did show that there was maybe a potential trend there that Eduardo might be familiar from what you were recalling. I think these studies are incredibly difficult, and partially, again, because when we randomize these individuals to different types of exercise, again, the type of exercise any one of us likes to do is very, very different. And so, again, in that Clausen paper, they were randomized to either stretching range of motion, resistive, or an endurance exercise, and that was done completely at random. So somebody who might have loved going to the gym all of a sudden was randomized to a stretching protocol, and again, that adherence there may be incredibly difficult. And so I think individualization of these exercise programs for these individuals and having that personal talk like you're describing, what do you like to do, what type of exerciser have you been? And as opposed to thinking about what might help, I think it's always important for us to know what might hurt and flip it in that direction. So what might be damaging in some of these exercise regimens and some of the high intensity, what types of strains, what types of respiratory training might not be advantageous for this population, I think is a critical question that we need to answer, as what type of exercise is best still hasn't been answered for the larger population in general. And so for us to tackle that in an MND ALS, I think is a huge task. But thank you so much for bringing this to the table today.
Thank you.
We have a question online, and then we'll go to Helen.
Should we be looking at measures like ALS, FRSR? I don't think we anticipate exercise improving scores, but should we be looking at more quality of life measures or measures that look at specific tasks, like the Berg balance, the 10-meter walk test?
I think we should probably ask people with ALS MND what their priorities are. I think working clinically, some people really focus around the functional and slowing the decline of the disease element of exercise, but some people definitely look at symptom management, depression, managing their pain, managing their swelling. So I think there's definitely space for a qualitative study to look at what types of outcomes are a priority for people with ALS MND. The ALS FRSR scale is nice for comparing studies with each other in future systematic reviews, so that's probably a good one to still include because it's so common. But yeah, perhaps we should be looking at different outcomes as well.
Lovely. Helen, do you have...
Lovely, thank you. And thank you very much. It was beautiful to see a systematic review and see somebody else stand up and say that, yes, you can exercise. I actually think that we need to move on from it now. We've had so many studies that say, yes, it's good to exercise, and this shows that it is good. I think we need to move on from randomised controlled trials. It's what people want to do. I think we need to move on from worrying about falls. The study that I did, people didn't fall. They actually improved hugely 24 hours post-exercise. What people did do was decondition. So if we keep asking, should we be exercising, we actually risk deconditioning lots of people. So brilliant to hear this. I think now we look at individualise what people want. And the other thing, sorry, and then I'll be quiet, I think it's very important for us to think that a lot of the people that we treat have had lots of exercise before diagnosis. This is their usual phenotype. It could also be their genotype. The worst thing we can do is stop them exercising when this was their normality. Thank you for doing it. Appreciate
Thanks, Helen. I really liked that question. I guess one of the big things that we did identify in this review is that there is a lot of information for people at those earlier stages and with minimal impairments. But as the disease progresses, that still hasn't really been tested. So I think there's room for more information and evidence around there so people can feel confident across the whole spectrum of their disease making those decisions. But yeah, thanks for that.
We have time for one more question.
Okay. Hi there. I'm Paula. I'm a person with ALS, and I'm a former personal trainer and whatnot, kinesiologist. But one thing that might be interesting to look at for somebody in the room moving forward, I'm on a drug called tofersen, and I've actually had symptom reversal. So a question I have, with people like this who are on this, when is the right time to start exercise? Again, probably any type of exercise, but how should that go and what are the expectations and whatnot? Might be something to look into.
Yeah, that's something that we'd love to know, is how people respond as their disease progresses, as their muscles get weaker, as those muscles are more affected.
And
how
is there
they
a plateau?
Exactly. Yep.
I'm loving these questions. There's actually we have one more for the lady.
Fantastic. Just a quick comment to build on what's already been said. It's very easy to get excited about exercise. I'm a physiatrist, and I found it very interesting that you pointed out that 12 out of 16 of the studies that looked at resistance exercise had modified protocols, but we really don't have any strong evidence in humans to make those limitations on type of resistance exercises. So as I was sitting with a person with ALS in my clinic and providing some guidance on resistance exercises and the limitations based on the evidence that we have, this person asked, why don't we have the evidence? That shouldn't be very hard to study. And he was absolutely right. So I think this is a great framework for the studies that we should be doing, and realizing how difficult it is with finding funding for that kind of study. But I totally agree. We should talk about what you can do rather than what you can't.
Okay, I think we have to call that a time now, because I think people will be very keen to have a cup of tea. Claire, thank you very much.
Thank you.